We are going to be talking about pelvic floor dysfunction in your current patient population. My name is Jill Cramp. Some of you read my bio. I've been doing pelvic health for over 21 years now. I work with all genders, all ages, and all diagnoses of pelvic floor dysfunction. The number of people that suffer in silence with pelvic floor dysfunction is a lot. And my goal for today is to just increase awareness, trying to get more medical professionals to pay attention to pelvic floor dysfunction, pay attention to the current population that we're working with, and being able to recognize pelvic floor dysfunction and get people into proper care. Given the fact that none of you are primarily in pelvic floor, then where is the pelvic floor? What does it do? The pelvic floor are the muscles that run from your pubic bone to your tailbone. And the pelvic floor has 5 primary functions associated with it. It supports your organs. It stabilizes your spine, your hips, your posture, so it provides that stability. All of their 5 functions start with S, so see if we can remember those: support, stabilize. It also provides sexual functioning, so the increase in blood flow to the clitoris, to the penis, can aid in vaginal lubrication as well, provides sphincteric control, so from the urethral sphincters and from the anal sphincters, so keeping things in when we want to keep them in and letting things out when we want them to come out. And it also acts as a sump pump for venous and lymphatic fluid to be able to get back into the venous and lymph system. So pelvic floor, 5 main functions, runs from the pubic bone to the tailbone. Just very briefly, but before we move on, my goal for today is to teach you about the pelvic floor. So where is it? You know, just briefly what it does. We just talked about the 5 main functions. I would like you to understand common symptoms of pelvic floor dysfunction over the next hour, understand how many people have pelvic floor dysfunction, people that you're currently seeing. And actually, I would argue there is 54 people in the room right now. I would argue that at least half of you, if not more, have some form of pelvic floor dysfunction. It is so common. I'd also like, before we end today, for you to recognize that pelvic floor dysfunction, it might be impacting your current patients, their progress towards the goals that you have set for them, because we may not be addressing their pelvic floor dysfunction. And if we do address their pelvic floor dysfunction, might that potentially improve their progress towards their goals? And then finally, like, what can we do about it? So we're gonna see where's the pelvic floor? What does it do? How common is it with the current patients that we're talking to? Is potentially pelvic floor dysfunction inhibiting their progress, that we're seeing them, that their progress towards their goals, and what can we do about it? So hopefully we'll be able to answer some of those questions as we go along. What is pelvic floor dysfunction? It can come in a variety of different presentations. It might be bowel and bladder symptoms. It might be pelvic pain. It might be back pain. It might be prolapse. It might be sexual dysfunction. It can contribute to back pain. It can contribute to hip dysfunction. It's something that we should be paying attention to in people with breathing disorders, in people with any kind of lung disorders. It can be present in people with TMJ, actually very, very common in people with temporomandibular joint dysfunction. It can be a result of fear and anxiety. We know that people, their pelvic floor muscles are one of the first muscles that responds to threat or fear of threat. It's not just pregnancy. It's not just postpartum. And it's not just little old ladies. We have got to change that, that myth that this is something that is just happening in the female population, and that is a problem with older people in pregnancy and postpartum. Again, I said that I work with all genders, all ages, and the prevalence of pelvic floor dysfunction in all genders and all ages is high, and we're going to learn that today. So really widespread impact of pelvic floor dysfunction. You're seeing these patients every single day in your clinic. If you've already saw 4, 5, 6 patients this morning, I would argue that probably most of them had some sort of pelvic floor dysfunction. And I'm hoping that as PTs, OTs, PTAs, OTAs, as anyone in the medical profession, that we do a better job of identifying symptoms and putting people on the right path to care. So some of the diagnoses that we'll see associated with pelvic floor dysfunction: pelvic girdle pain. We know a huge percentage of low back pain, very common to have pelvic floor dysfunction coupled with that. Coccydynia, or tailbone pain. Remember how I said that pelvic floor muscles run from the pubic bone in front to the tailbone and back? So there's that insertion of those pelvic muscles can contribute highly to tailbone pain. Testicular pain can be a form of pelvic floor dysfunction. It can also be coming from the spine commonly as well. Vulvodynia, which is pain in the vulva, the labia, the clitoris. Dyspareunia, which is pain during intercourse. Back pain, because it's relationship. Pelvic floor, remember we said the 5 main functions, one of them is to stabilize the spine. It is one of your core muscles, should be paid attention to as we're working with people with back pain. Pelvic organ prolapse, where in people who have a vagina, the bladder, the rectum, the uterus start to descend down into the vagina and kind of herniate into the vaginal walls. Various neuralgias from nerves that supply the genitalia and supply the pelvic floor, whether that be pudendal nerve, ilioinguinal nerve, ilioepigastric nerve, genitofemoral nerve, cluneal nerves, femorocutaneous nerves, bunch of nerves in that area that could be contributing. Dysuria, pain during urination. Endometriosis, very common to have pelvic floor dysfunction in that population. 1 in 10 women have endometriosis, so we're seeing these people in our clinic. Urinary urgency, frequency. If you're going to the bathroom more than once every few hours during the day, and if you're getting up at night, that might be overactive bladder. Getting up at night is nocturia, so that's another symptom. Nocturnal enuresis, or bedwetting. Urinary incontinence, whether that be from coughing, laughing, sneezing, running, jumping kind of activities, pushing, throwing, anything that increases your intra-abdominal pressure, that's stress urinary incontinence. Or it could be urge urinary incontinence, where you get an urge to pee and you can't make it to the bathroom in time before some dribbles out, or you lose total control. Fecal incontinence, where we're not able to keep things in our rectum and our anus, and so we're losing stool. Constipation, form of pelvic floor dysfunction. Huge numbers of people with constipation. Does that lead to hemorrhoids, anal fissures, and just mood changes? Like if you're not pooping, you're not happy. There's actually some, serotonin, like feel-good hormones, are released with bowel movements. So definitely something that we can do as pelvic therapists for constipation. Interstitial cystitis, which is the inflammation of the bladder wall that can have painful bladder syndrome, irritable bowel syndrome, erectile dysfunction. This is just a small list to give you some ideas of what pelvic floor therapists are working with. And there's PTs and OTs in the pelvic floor world. So a lot of people say pelvic PT, but I have many OTs working for me. I'm in Maine and New Hampshire, and I have probably 5 or 6 OTs right now that are doing primarily pelvic health in that population as well. So just a small list of some diagnoses that we'll see with pelvic floor dysfunction. So how common is pelvic floor dysfunction? Well, last I checked, 1 out of every 1 people have a pelvis. So how common is pelvic floor dysfunction? It's quite common. We see a huge number of people with constipation, with bladder symptoms, with sexual symptoms. Every single female assigned at birth who's fortunate to live long enough will go through menopause. We know that menopause can contribute to some of these symptoms that we mentioned earlier. So huge numbers of people. We're going to talk about some of that today. In the United States right now, about 1.7 million people have prosthetic legs. In school, to be a PT and OT, a lot of times we learn about prostheses, prosthetic and orthotics. Some schools dedicate an entire semester of training to this population. There's 1.7 million people with prosthetic legs, something that we should learn as therapists, right? However, there's 25 million people with urinary incontinence, more than 25 million people with urinary incontinence. So 1.7 million with prostheses, more than 25 million with urinary incontinence, but there's not a whole lot of people that learn about that or that treat that. Similarly, we have 1 million people in the United States with multiple sclerosis. We have another million with cerebral palsy. We have another million with Parkinson's disease. As therapists, these are not uncommon diagnoses that we work with, especially if we're working in that neuro population, in acute care population, an outpatient population, multiple sclerosis, cerebral palsy, Parkinson's disease. We work with, we have familiarity with, but 42 million people have constipation. So that's 3 million total with MS, CP, Parkinson's, 42 million people with constipation, and we're not servicing them well. 18 million people in the United States that are not in an institution, more so in an institution, 18 million that are not in an institution have fecal incontinence. How much does that affect people's quality of life? If you're not able to poop, you either can't keep it in, you're incontinent of it, or you can't get it out, you're constipated, or you're leaking urine during the day. So huge numbers. 10% of the population in the United States has pelvic organ prolapse. That's what POP stands for, pelvic organ prolapse. And that's where the uterus, the bladder or the rectum start to herniate down into the vagina. That's 10% of the population. We're not necessarily paying attention to that. This study in the Journal of Urology last year just kind of blew me away. 79% of people in the United States have lower urinary tract symptoms. What are lower urinary tract symptoms? Lower urinary tract symptoms are some of those things that we mentioned before, like incontinence, like dysuria, painful urination, inability to empty your bladder completely, those types of things. Chronic urinary tract infections, 79% of people. The interesting thing about this is that there's a large number of those that are moderate to severe, and nobody's getting treatment. Only 7.1% of them are actually seeking treatment. And why is that? A large part of that is that they just normalize it and they think that there's nothing that they can do about it. And that's where I think we as medical professionals can be a game changer in these people's lives and say, hey, do you know that there's help for that? Do you know that you don't have to live that way? Even if your grandma and your mom and your aunt lived that way, doesn't necessarily mean that you have to live that way. Huge amounts of sexual dysfunction among men and women, erectile dysfunction affecting, 50% of men over the age of 40. So huge numbers of people with pelvic floor dysfunction. What about pelvic pain? Chronic pelvic pain, we see 6 to 26% of people with chronic pelvic pain, and not a whole lot of people know what to do about it. Endometriosis, we mentioned that a little bit before. 1 in 10 women in the country have endometriosis. Endometriosis is a diagnosis that often goes missed. It usually takes up to a decade for people to get diagnosed with endometriosis, and multiple providers that often people have gone through before they get that diagnosis of endometriosis. Vulvar pain, 8 to 12%. Testicular pain, 100,000 men in the United States each year are diagnosed with testicular pain. And nobody knows why in 50% of them. And I would argue that half of that is because they're not seeing therapists who can look at the spine. They see a urologist who does an ultrasound, does some blood work, says, we don't see anything, we'll put you on antibiotics. But they're not really looking at all of the other things that can be contributing to testicular pain. Oftentimes, testicular pain is coming from the spine. I think it's kind of like sciatica of the testicles. So it can be a nerve issue for sure. Same thing with vulvar pain. And that's honestly a mistake of a lot of pelvic therapists. I think a lot of pelvic therapists get really just stuck in the pelvis and don't look above and below for things that are in the pelvis, like testicular pain, like vulvar pain, but is that coming from other areas? Is that coming from the back? You PTs in the room know how to work on a back. And so is this something that we should be working with more often? Pelvic girdle pain, this is during pregnancy. 60 to 70% of people in late pregnancy have pelvic girdle pain. What about working with the oncology population? 2 million people a year are diagnosed with cancer, and your lifetime risk of developing cancer is 40%. So huge numbers of people with cancer. Constipation affects about half of those with cancer. Chemo-induced constipation has been well studied in adult oncology literature, is the third most common unwanted side effect in patients receiving cytotoxic chemotherapy. Very, very, very common that people will have constipation that are receiving chemotherapy. I had a patient once that I was discharging, and she was somebody who had breast cancer, and she was sent to me for her constipation. And when I discharged her, she kind of, looked at me and grabbed my hands, and she said, "Jill, I just want to tell you that breast cancer almost took my life." And she said, "But I almost took my own life because of my constipation. I wish I would have met you sooner." And that really, it gives me goosebumps whenever I say that, because it really was profound for me. And it was like, why are we not doing a better job of educating people on what we can do for constipation? People suffer so much with constipation, and there's a huge amount of help that therapists can give to people with constipation. Huge amounts of help. So think about that with your cancer population, but with anybody with constipation and how that can affect their mood, their behavior, obviously their energy levels, their discomfort, their back pain, all of those things can be contributing to constipation. It can be an early sign of different cancers as well. Constipation we see as an early sign to different cancers as well as early sign to different diagnoses. Chemotherapy-induced constipation, 50 to 87% of patients receiving chemo-induced or cytotoxic chemotherapy will have constipation. This slide's a little bit of a tongue-in-cheek kind of slide. Does urgency kill? And so the reason why I put this is because we know that a lot of people with bladder urgency, oh my gosh, I have to go pee so bad, are rushing to the bathroom, right? So they're afraid they're not going to make it to the bathroom. They're going to pee their pants before they get there. They're rushing to the bathroom. We know that a lot of people fall on the way to the bathroom. So when I say, does urgency kill? We know that a lot of people that fall, it can be related to death. And so think about somebody with a femur fracture and how that can lead to death from a fall. So a little bit of tongue in cheek, but there are, 46,000 deaths in the United States related to falls. And how many of those, I know there's at least a percentage of those that were falling on the way to the bathroom. So similarly, if we're working with patients with osteoporosis, we want to be preventing falls. We want to be asking them about their bladder habits and their bowel habits, because if they're rushing to the bathroom, then are they going to be more apt to fracture? Similarly, we're also working on balance with our osteoporosis population. Remember, the pelvic floor is something that provides stability. And so we want to be able to pay attention to their pelvic floor as we're working with somebody with osteoporosis. We also know with osteoporosis, we're going to load, right? We want them to load in order to promote bone mineral density changes. And if we're loading the system, sometimes you might find that patients are afraid to load because they're afraid they're going to leak urine, leak gas, leak stool. But if we're not paying attention to that, we might miss some of those opportunities to discuss that with our patients. Physical inactivity is a major public health crisis. It leads to obesity, it leads to diabetes, it leads to cancer, it leads to cardiovascular disease. We know that cardiovascular disease is the #1 killer of both men and women in the United States. We also know that a large number of people stop exercising because of pelvic floor dysfunction. So if we think about how important exercise is for all of these things, how important it is for cancer, how important it is for diabetes, how important it is for cardiovascular disease, how important it is for obesity, but some people aren't exercising because of their bladder issues or their bowel issues or because of their pelvic floor dysfunction, something that we want to be asking people. Similarly, we see a big correlation between cardiovascular disease and lower urinary tract symptoms, which we said before was, getting up at night to pee, urgency frequency, and not being able to empty completely, UTIs, those types of things, incontinence. BPH is benign prostatic hypertrophy. So it's showing here in the picture that a normal size prostate versus an enlarged prostate. And we know that enlarged prostate can be associated with cardiovascular disease and lower urinary tract symptoms. We definitely see a correlation with lower urinary tract symptoms, but we also know that moderate to severe lower urinary tract symptoms, patients have an increased risk of a major adverse cardiac event. Obesity is a risk factor for benign prostatic hypertrophy, heart disease, increased risk of BPH, of that hypertrophy of the prostate. So something that we can be paying attention to. There was a number of you on the call right now that work with the pediatric population, you said. So is this common in kids? Like, I thought this was just a pregnancy, postpartum old lady issue. Is it common in kids? Constipation can affect up to 29% of pediatric population. We see in my area in Maine and New Hampshire, I have a bunch of pediatric pelvic PTs and OTs that work with kids with constipation, with bedwetting. Huge number of people that are constipated as kids, and that results in bedwetting. Huge number of people that are constipation as kids, and it leads to behavior issues. We see constipated kids can have different behaviors. We see it lead to kids going home with belly aches, with tummy aches, and people not paying attention to, is this a bowel issue? So something that we want to, and we see these people turn into adults with constipation because we're not treating it as kids. Almost 20% of kids have lower urinary tract symptoms. So again, is that incontinence? Is that overactive bladder, urgency frequency kind of issues? Is that bedwetting? Is that pain during urination? All of those things that we talked about. Huge number of people with lower urinary tract symptoms on the autism spectrum disorder. Enuresis, is that bedwetting? 15% of 5-year-olds are wetting the bed at night. Something that we can work with. This study here put out a few years ago, it was a systematic review. I believe it was urinary incontinence in adolescent athletes. And in this study, they looked at the average age of the adolescent athletes that they looked at. And it was all females. The average age was 16 and a half. So 16 and a half-year-old people with vaginas, 48% of them had urinary incontinence or lower urinary tract symptoms. That's mind-blowing to me. And it makes me wonder if these athletes, are they the ones that all of a sudden, decide that they don't like to play basketball anymore? And is that because maybe they're leaking urine and it's embarrassing to them, especially at the ages of, those middle school, high school years? Is this the track athlete that says, you know what, I'm just going to concentrate on my studies this year, I'm not going to run? And maybe they're having symptoms that nobody's addressing because we're not talking about it. What about the neuro population? 1 out of every one of these people also have a pelvis. If we look at cerebral palsy, 55% has 1 or more symptoms of lower urinary tract symptoms. 57% of people with cerebral palsy have constipation. 81.5% have low quality of life. This is my daughter here in this picture. She has cerebral palsy. She has grade 4 cerebral palsy. She was in PT, in OT, in speech. She saw every specialist from physiatrist, orthopod, cardiac, complex case management. Like, she had seen, so many different providers throughout her life because of her heart disease and her cerebral palsy. Nobody ever mentioned her being toilet trained. Until I started working with this, she's 24 now, and I've been working in pelvic health for 21 years. I was a physical therapist before that, but nobody ever addressed, hey, let's get our toilet trained, until I started taking courses. I'm like, why are we not doing this with people with severe physical and mental disability? She's toilet trained now. And I think it's something that if you're working with that pediatric population, we have to be paying attention to. This is such a huge quality of life issue, not only for the child or the adult with CP, but for their caregivers. Having to take a 12-year-old who's larger than the public restroom diapering stations to change their pants is a huge quality of life issue. And we already know that how quality of life is impacted in people who take care of these people and for the people themselves, that I think that that's one huge way that we can impact them. Multiple sclerosis, large number, like 87% of people with multiple sclerosis have lower urinary tract symptoms. I was reading a study once on multiple sclerosis, and it was listing the things that affected their quality of life the most. And I would think like, okay, multiple sclerosis, fatigue, huge, muscle spasms, huge, right? Their bladder symptoms rated significantly higher than fatigue and muscle spasms. But are we necessarily paying attention to that? We should be. 82% of them constipated. Most of them, or half to almost all, reported sexual dysfunction. Parkinson's, 61%, 64% with constipation. So huge numbers of people with bowel and bladder disorders. What about our sports population? So there's a bunch of you that work in the outpatient ortho environment, working with athletes, working with sports injuries. 3 million vaginal births are had in the United States per year. 19% of them sustain a birth injury. So that's 570,000 birth injuries a year, whereas only 200,000 people suffer an ACL injury. We all know, PTs all know about ACLs and ACL injuries and repairs, right? But 200,000 compared to 570,000 birth injuries, something that we're not really paying attention to. 47% of women with past symptoms, current symptoms, or even a fear of pelvic floor symptoms, it adversely affects their participation in sport. And so if these people are like, oh gosh, I don't know if I can do that. I can't run because I'm afraid I'm going to leak. Or I can't do that box jump because the last time I did it, I leaked. Or I can't give it my all when I'm doing this sport. I can't swing the bat as hard. I can't throw the shot put as hard. I can't do that hurdle as much because I'm afraid I'm going to have symptoms. Significant effect on their participation in sports. 33% of elite athletes. So this is not just you're overweight, you're out of shape kind of thing. These are elite athletes. 33% of them are leaking urine. So if you're working with a sports population, we have to be asking these questions. I started working at our only Division I school here in Maine, and I was working with football players. And they, knew that I was a pelvic health therapist, but they had unrelenting hip pain and back pain that it hadn't improved. A couple of them had surgery. They're in the training room every single day. They're seeing PTs, but nobody had ever paid attention to the pelvic floor, despite all of the intervention that they were getting from physicians, from ATCs, and from PTs. And it's amazing to me how many of those athletes with hip injury, back injury, also had sexual dysfunction and had difficulty getting an erection, because the muscles of the pelvic floor are also responsible for sexual symptoms. So something that, of course, not the other therapists hadn't asked them about, but really cued into me, like, okay, this is a pelvic floor driver that nobody's been paying attention to. Lumbopelvic pain, 95% of people with lumbopelvic pain have pelvic floor dysfunction. And then we've seen studies on how pelvic floor muscle strengthening can significantly reduce back pain intensity. We need to be paying attention to these. There's a lot of studies that have done that show the relationship between back pain, incontinence, breathing disorders, respiratory conditions, and GI symptoms. We know that those with back pain at baseline, it's associated with the development of GI symptoms, breathing problems, and incontinence. And the same thing in the reverse. People with incontinence at baseline, they're much more apt to develop breathing problems, back problems, and GI symptoms. Why is that? Because your pelvic floor is part of your core. The pelvic floor is the bottom part of the core, and the breathing problems, your diaphragm, your respiratory diaphragm is the top part of the core. For some reason, we don't teach that in school. We only teach that the core is the abdominals. Huge mistake that we're missing the core. I'm going to talk more about that in a minute. How many muscles attach to the pelvic girdle? A lot. I think I have 42 muscles listed here that attach to the pelvic girdle. It's not just a GYN issue. It's your back, it's your hips, it's your posture, it's your breathing, it's movement, it's balance, it's static balance, it's dynamic balance. 42 muscles. It's not just pelvic floors, it's not just pelvises. I do a lot of teaching across the country, teaching of therapists. And one of the questions that I used to ask all the time in the beginning are, give me the muscles of your core. And hands down, I would argue that 90% of the time, I would get rectus abdominis, obliques, transverse abdominis, everything in the front of the abdominals. Sometimes I would get multifidus, those deep low back muscles, but never did I get pelvic floor and diaphragm. The core has a top, a bottom, a front, and a back. If we're doing core strengthening and we're only paying attention to the abdominals, we're missing the boat. We need to be paying attention to the top of the core, the bottom of the core, the respiratory diaphragm, the pelvic diaphragm, and not just the abdominals. I'm from Maine, so fellow New England sports followers might know who this guy is in the upper right-hand corner. He was former longtime head coach of the New England Patriots, Bill Belichick, and he is very well known for saying, do your job. And I put him there because as a physical therapist, principle number 8 of the APTA Code of Ethics says physical therapists shall participate in efforts to meet the health needs of people locally, nationally, or globally. And one of the 7 core values of the APTA is social responsibility. And I feel like it is our social responsibility and our meeting the health needs of people locally, nationally, and globally is to pay attention to some of these huge quality of life issues. We know the numbers are out there. We know how much it impacts quality of life. We know how much it impacts mental well-being as well as physical well-being, but we're ignoring it. Why are we ignoring it? We're ignoring it because maybe it's in an area of the body that is shameful. The nerve that supplies the pelvic floor muscles is called the pudendal nerve. It stems from S2, S3, S4. The Latin nerve root to the word pudenda, which the pudendal nerve is derived from, means body parts to be ashamed of. And so why in 2025 are we still teaching that we can't mention anything in that area? Because it's shameful. I feel as medical professionals, it should be something that we're using as a differential for so many different things in order to be able to improve our patients' quality of life and well-being, their overall health and well-being. So how are we going to recognize pelvic floor dysfunction in our current population? What are going to give us some clues to say, maybe I need to get into some more questions about pelvic floor? Some things that we might see our patients do is we might see them toileting just in case before treatment. You know, we're going to ask them to do something. Oh, I better go pee first. Or after treatment or before exercise, if you're asking them to do any plyometrics or any kind of loading or lifting challenges, oh, let me go pee first. That might be a great opportunity for you to be like, you know, do you have any issues with bladder leakage? It's not uncommon with people with your symptoms or whatever, and saying this is not uncommon. Are you having those issues? Do we know that there's help out there for you that you can get help from this? We might see increased tone in people's jaws. If you're working with people with TMJ, they have pelvic floor dysfunction. So many of them. have pelvic floor dysfunction, if we're seeing that tightness in their jaw, in their glutes, in their abdominals, that would clue us into having pelvic floor dysfunction as well. Anxiety, I mentioned a little bit before, but we've done studies on people. They had them go into watch a scary movie, and they had them hooked up to EMG in a whole bunch of different areas of the body. And they were recording which muscles responded first to fear, anxiety, threat, and pelvic floor and your upper traps were the first muscles to respond. So people who are living in fight, flight, or freeze of the nervous system, part of the nervous system all the time, it might be really hard for them to relax their pelvic floor if they're guarding and protecting from that. So that might give you an idea of, is this somebody that is having some pelvic floor issues? If somebody's wearing pads, that's going to clue you in to them having some incontinence issues, perhaps, or fear of incontinence issues. If people are unable to sit comfortably, then that might lead you to say, is this more than just your back? Do I need to get down lower and start asking about other things? People that cross their legs like really tightly, you've seen that person who's like always crossing their legs and shaking. That might be somebody, because your adductors are connected to your pelvic floor as well. So that might be something that we're seeing some of that increase in tension in that area of the pelvic floor. Some medical history that might clue us into, okay, do I need to ask more questions? Is some of their symptoms related to the pelvic floor? If they have a history of endometriosis, very common that they'll have pelvic pain. They might have painful intercourse, difficulty using tampons. They might have abdominal pain. They might have bladder frequency, urgency. They might have irritable bowel kind of symptoms, constipation issues. If somebody has a history of cancer, definitely we want to be asking about their bowel bladder habits, about their sexual functioning, and can we get them into correct hands? If they've had a fall on their tailbone, that might clue us in, because remember, those pelvic floor muscles attach pubic bone to tailbone. So if that area is affected, is that contributing to some pelvic floor issues? We know as people get older, go through menopause, that your people who have a vagina, their vagina is estrogen driven. There's a lot of estrogen receptors on the urethra, on the anal sphincter, in the vagina. And so if you are perimenopausal, postmenopausal, if you're nursing, that also decreases your estrogen. If you're a lactating person, if you are on medications for breast cancer that are hormone depriving of your estrogen, or if you have, sometimes in our endometriosis population, unfortunately, we'll see people be put on some of those medications as well that can decrease estrogen. And so that can contribute to some symptoms of pelvic floor issues. Childbirth, obviously, we can, before I retire, one of my goals is that every single postpartum mom receives a referral to pelvic therapy, because if you think about like a tear in those muscles, the perineal body is the area between the opening of the vagina and the opening of the anus. That's where they might do an episiotomy, or that's a very common area for somebody to tear and have a perineal tear during childbirth. A 4th degree perineal tear goes through the anal sphincter. So if we can think of that, if we can think of a full thickness, like a 4th degree perineal tear, it's very similar to have a full thickness tear of a rotator cuff. We would never say to somebody who had a rotator cuff tear, oh, just go do your normal stuff, take care of all your other children, do your normal housework for the next 6 weeks, and then after 6 weeks, you'll be fine. You can just return to throwing that baseball again. We would never say that to somebody with a rotator cuff injury, right? We would say you need therapy before you can use that shoulder properly. Yet we'll have somebody who will have a full tear of their perineal body and their perineum, and just expect them to be able to have the same stability of for their back, for their hips, for their spine. We'll expect them to have the same support for their bladder, their rectum, their uterus. We'll expect them to have the same sexual functioning. We'll expect them to not be incontinent and not have any issues with that area of the body, and it's just supposed to heal naturally. These people need therapy. If they have a connective tissue disorder, that might be something that clues us into, are there some issues of laxity that could be contributing to some of their symptoms? And could it be causing some symptoms of pelvic floor dysfunction that they might not be disclosing to you? They have a history of constipation, and then we're seeing them for back pain or for hip pain. Are the muscles of the pelvic floor not able to relax? Does that contribute to some of their hip or back symptoms? If the muscles of the pelvic floor are not able to relax, then are the muscles around the pelvic floor have symptoms for that? Similarly, if the muscles of the pelvic floor are weak, are other muscles, back muscles, hip muscles, saying, hey, I need to step up to the plate a little bit more because those muscles aren't doing their job fully? Do they see a urologist? And, you know, if you're doing their medical history, their subjective history, are they seeing a GI doctor, any other specialist, urogynecologists? Have they had any abdominal or pelvic surgeries? Have they had hip, spine symptoms or surgeries? That I feel like anybody that has these, I feel like any patient that we see, we should ask about bowel, bladder, and sexual symptoms in order to see if this is something that we need to put them into another therapist. We make a referral to another therapist to say, hey, there's help for you, or to be able to use that as part of our differential and to change our treatment program. So what are we going to do? How are we going to ask these questions? Typically, I like people to if they're not working with the pelvic health population, they're seeing back pain, they're seeing hip pain, they're seeing somebody with CP, with MS, they're seeing just an athlete. I think it would be helpful for us to say, how often do you empty your bladder? And if we see somebody says, oh, you know, I empty my bladder every half an hour, then that's something that we can educate them on. You know, you're only supposed to empty your bladder, you know, about once every 3 hours during the day. You're not supposed to get up at night. Do we need to send them off to somebody who can treat them? Another question that we can ask is, do you leak urine with laughing, coughing, sneezing, running, jumping kinds of activities? If you ask somebody if they're incontinent of urine or stool, they will say no. If you ask somebody if they can jump on a trampoline or cough, you know, for a minute without losing control of their urine, they might change their mind on that and say yes. So most people are going to say that they're not incontinent. However, urinary incontinence is any involuntary leakage of urine, not just like I need to wear 10 diapers a day, you know? So we want to ask, are you leaking urine with laughing, coughing, sneezing, running, jumping, or on the way to the bathroom if you're in a hurry to get to the bathroom? How often do you have a bowel movement? That's going to clue us in. Is their pelvic floor contributing to some of their symptoms? If they're only having a bowel movement once every 4 days, is that pelvic floor not able to relax? Is that contributing to some of their other symptoms? Do you have any pain or strain to empty your bowels? Do you have any history of hemorrhoids or fissures? So these are all just very easy subjective questions that we can ask. And then on the sexual side, do you have any difficulty or pain with erections, with orgasms, or with sexual activity? So very simple. How often do you empty your bladder? Do you leak urine? How often do you have a bowel movement? Is it painful? Do you have any straining? And then any difficulty or pain with erections, orgasms, or sexual activity. So we're asking the pee, poop, and sex questions. Those pee, poop, and sex questions are going to lead us to then say, could this be a pelvic floor contributor to their symptoms? Because they're having some of these things. So I'd love for people to get comfortable using those questions in their subjective history. It's really hard though, because we haven't been trained that way. And so a lot of therapists are like, oh, I'm not going to talk about pee, poop, and sex. And with my patients, we've done studies where we've seen like such a huge number of people with these symptoms and that nobody ever mentions it to their doctor. But they'll say, if my provider asked me about it, I'm much more apt to bring it up to them. Patients might feel really ashamed about talking to you about bladder leakage or constipation or sexual symptoms. But if you said to them, hey, you're having these symptoms, it's not uncommon to have bowel, bladder, and sexual symptoms, and ask you a couple questions about that. Or, you know, hey, like you have whatever, cerebral palsy, multiple sclerosis, Parkinson's disease, osteoporosis. Like we see a correlation of pelvic floor dysfunction with this population. Are you having any bladder issues? Do you leak urine at all with coughing or sneezing or with urgency? How often are you having a bowel movement? Are you having any troubles having a bowel movement? Just like saying that it's normal to have these, and then patients are going to open up about it. And I think it's more our reservations on asking about it than the patient's reservations. They want to be asked because they're suffering with these things and they have no idea that there's anything that they can do. So then what? So we've asked some of the questions. So we know that it's a huge issue across all genders, across all ages. It's not just a little old lady problem. We know some of the symptoms of pelvic floor dysfunction. We've asked some of the subjective questions, but then what? Then what do we do? Unfortunately, there is not everybody's trained in pelvic health. I think there are some things that you can do as the current therapist the knowledge base that you have right now. We can assess what we know. Like, look at their hips, look at their spine, look at their abdominals, look at their diaphragm. Most people are not trained in how to assess the pelvic floor, even externally. I'm hoping that changes over the next decade as we educate our new clinicians. I'm hoping that we start to incorporate more pelvic dysfunction into differentials and into schooling, because I don't want pelvic health specialists to be so special. I think that pelvic health specialists should be the ones that we refer to people, if all else, if they can't make improvements with their regular therapist. But I think regular therapists should be asking questions. We're just not there yet. Pelvic health therapists now have done a lot of extra training to get to where we are today. But I'm hoping that that is something that becomes more of the norm as the years go on. I don't want to see PTs, OTs, assistants ever asking if men have pelvic floors. I've seen this way too many times. Men have pelvic floors? Yes, men have pelvic floors. I don't want PTs and OTs to not know what the core muscles are and think that it's just the abdominals. So we need to do a better job in being able to identify these symptoms and then to refer people out to the proper care if they're having any of these symptoms. So that wraps up my prepared part. I'm hoping that it gave you some things to think about. I'm going to open it up to the Q&A. So if you have any questions, you can type them in the Q&A portion here. Looks like, can you please share a resource I may use to help address the many pediatric patients I see who need help for GI issues in those who hold their bowel and bladder? Heather, this is so common. And I feel like I said, my daughter has cerebral palsy. None of the PTs and OTs ever addressed her bowel and bladder issues. So I applaud you for even knowing that your many pediatric patients have GI issues. And there's a lot of holding for that. Is there a resource? I would say find a pediatric pelvic therapist in your community. Is there a website? Dawn Sandalcini teaches the kids bowel and bladder courses. Or she has a website where I know she does so I think she might have a website that tells who teaches or who treats pediatric populations across the country. That would be my best thought, is for you to find a pediatric pelvic OT or PT in the area. If you're working with the pediatric population, first of all, like, you could have them, one of the big things is ritualizing their toilet sits and decreasing any fear or anxiety around the bathroom. A lot of these kids have a fear of the bathroom or fear of the flushing of the toilet. Those automatic flushing toilets are horrible for a lot of kids. A lot of kids aren't supported on the toilet, and so they have to hold, if they have any tonal issues, then having to support their balance on the toilet can inhibit their ability to relax their pelvic floor, can make them feel unsafe on the toilet. So that's a big thing. There's so much to go on down there. Maybe I'll do a lunch and learn on peds at some point. But my best thought is to find somebody in your area. Diaphragm plays an essential role in pelvic function. What is better to contract pelvic floor muscles during exhale or inhale? So the respiratory diaphragm and the pelvic diaphragm
work together. So typically when you take a deep breath in, as you breathe air in, your lungs expand. So your ribs should expand laterally and posteriorly. Your diaphragm, your respiratory diaphragm contracts down. When we take a deep breath in, our respiratory diaphragm contracts down. And so then our abdomen is like, whoa, I got to expand in order to create room for this diaphragm and that pressure, room for my organs. So your belly expands. And then your pelvic diaphragm, those muscles also expand and relax. So let me do that again. Respiratory diaphragm, we take a breath in, everything should expand. We're breathing like into a balloon here. So think we're blowing up a balloon from here to below your pelvic area. We're putting air into our system. Diaphragm's going to contract down, belly expands, pelvic floor relaxes and lengthens. It works like a piston. Diaphragm, pelvic diaphragm. Let me push one of those images here. So if we look at this picture here with the respiratory diaphragm on top and the pelvic diaphragm on bottom, as that contracts down, pelvic floor also relaxes and lengthens. When we exhale, the diaphragm goes back up, our belly flattens because we don't need to create room for our organs anymore, and our pelvic floor goes back up. So it works like a piston. Your respiratory diaphragm and your pelvic diaphragm, they work like a piston, and they work in unison. As we take that deep breath in, pelvic floor should relax. On exhale, it should kind of recoil. So that can be something that we're working with our patients. And so much more. Is it better to contract the pelvic floor muscles during exhale or inhale? The pelvic floor is already recoiling on exhale. And so we're going to get that natural recoil on exhale. So that might be where we start our training, but ultimately we want people to be able to contract them in no matter what part of the breathing pattern they're in, depending on the situation. Do you have a recommendation or on a textbook that you have found helpful? Textbooks, I mean, this is kind of off subject, but it depends on what you are, what population you are thinking about. Come As You Are, Emily Nagoski is a great book for sexual issues. The Fifth Vital Sign, that's another good book. The Ultimate Cock Block is a good book for male pelvic pain. Those are a few off the top of my head. There are a number of books. Any tips for knowing when to do bowel bladder training in older adults in long-term care? One of the number one reasons for institutionalization, I think it's the second leading cause of institutionalization, is bowel and bladder incontinence. Because think about it, if you you're getting older, you move into a family member's house, they're taking care of you. Once you start peeing and pooping all over the place and all the laundry, it's much more of a burden on family. And does that lead them to say, okay, like we can't do this anymore? For example, I sometimes struggle knowing when improvement can be made and when it is general natural decline that cannot be retrained. Peyton, great question. So they've done studies on people with severe cognitive issues, dementia, and improving their pelvic floor symptoms. And remember how I said that the pelvic floor muscles are attached to your hip muscles are attached to the pelvic floor. So your obturator internus is the lateral walls of your pelvic floor. Your obturator internus does hip external rotation. So they've done studies on just people strengthening their hips and getting their hips stronger and improving their bowel and bladder incontinence. So if we think about our elderly population that's institutionalized, maybe even like cognitively, like they're not able to say, okay, how do I do like a pelvic floor contraction? And we didn't even really get into how do I do that on this call. But if you can't get into like, oh, you need to close your vagina, close your rectum, those kind of cues for like a pelvic floor muscle contraction or relaxation, can we strengthen their hips? We know that people with lower urinary tract symptoms, strengthening their hips can significantly improve their symptoms. We know that people with, there's been studies done on people with lower urinary tract symptoms, and the only thing that they did was strengthen their hips, and we saw an improvement in their pelvic floor function. We've seen improvement in pelvic floor strength and endurance when they didn't even work on their pelvic floor, but they were working on the muscles associated with that. So I think that is something that we can do. I always think constipation, 100%. I mean, these old people, like that's one of their biggest topics at the lunchroom, right? Is have have they pooped today? And so I feel like we can definitely, there's so much that we can do for bowel habits. We can get them into a right position. We can teach them how to relax their pelvic floor. We can teach them how to breathe. We can work on abdominal massage, which has grade A level 1 evidence for it. We can work on diet stuff. We can work on how do we activate the nerves, the part of the nervous system that allows for rest, digest, and heal, and not get these people just in sympathetic overdrive, the fight, flight, or freeze. So much we can do with that population for bowel and bladder training. I would not say that they are too old and it's a natural decline that cannot be retrained. I would say at a 99-year-old person, we can work on that for sure. To get approval for this, to get treatment approval for this condition, does the MD need to write special particular CPT code that insurance will cover? Gladys, it depends on what part of the country that you're in. It is covered. I'm a physical therapist. It's covered in, like I said, I have a bunch of OTs that work with me as well. It's covered the same CPT codes, you know, Therarex, therapeutic activity, self-care, home management, manual therapy, neuromuscular re-education. We use all of those same billing codes. And we have direct access. We don't need doctors to write a special thing for some people who are able to do direct access. But it's just like any other PT diagnosis. It's a muscle issue. And so typically it's covered just like other diagnoses are. All right, I think I answered all of the ones in the chat, and that brings us conveniently exactly at 1 o'clock. So thank you all for sharing your lunch hour with me. It was a pleasure, and I hope it left you with just a little bit of a nugget of something that you might be able to think about in working with your current population. All right, goodbye, everyone.